Right, good afternoon, grade 11s. This did start off as being this good morning, grade 11s, but somehow I had managed to switch off the recording device on this computer. I have no idea how, and so I have just spent 4 hours trying to sort it back out. We nearly had a teacher who had lost her voice. Not in the conventional sense. Right, so this is a new PowerPoint on Gaseous Exchange, and it will last you for 2 lessons. So this will be lesson 6 and lesson 7. Okay, so that should last for both of the choices because you're now out of sync in terms of when these lessons will happen. It should last you for Thursday, Friday, and Monday. Okay, let's go. So this particular PowerPoint is about lung capacity and then also about lung diseases. So we're going to start off with lung capacity. First of all, different animals have different lung capacities depending, based basically on their activities. So cheetahs, for example, have a very much higher lung capacity than humans do. And the reason for this is it helps to provide adequate oxygen to all the muscles in the body and allows them to run very fast. Now here I need you to think back to your lessons on cell respiration, which you did last term. And if you remember, there are 2 types of cell respiration. There's aerobic, which occurs when there's adequate oxygen present, and that's very efficient because it releases 38 molecules of ATP per molecule of glucose going into the cycle. Anaerobic occurs when there isn't an adequate amount of oxygen present, and it's very, very inefficient. It produces 2 ATP per molecule of glucose going in. And so you can see that it is far more effective for an organism to do aerobic respiration than to do anaerobic respiration. Now, many organisms are able to do both. For example, you know that humans are able to convert from aerobic respiration to anaerobic respiration if there's not enough oxygen going to the muscles, for example. And it's very inefficient. And so cheetahs, by having a much higher lung capacity, are able to provide their muscles with an adequate amount of oxygen for a far longer period of time than humans are able to. So it's very much more efficient than it is in humans. Elephants, on the other hand, have a high, also, I shouldn't have said on the other hand, elephants have a high lung capacity, but for a different reason. Not because they run fast, they don't really run very fast, although they are able to move actually very fast, even though it doesn't seem so. But they have a much higher lung capacity than humans because they have a large body. So this relates back to surface area and volume. To be able to take up enough oxygen for the huge volume of an elephant's body, they also have to have a high lung capacity to make sure that the ratio of surface area to volume is adequate. Okay, so human lung size is determined by genetics, by gender, by height. At maximal capacity, an average lung can hold almost 6 liters of air. Sorry, here it's actually both pairs of lungs, just be aware of that. And however, they don't usually operate at maximal volume, maximum capacity. Okay. So we're going to talk about a piece of apparatus called a spirometer, which measures the volume of air entering and leaving the lungs. So I'm quickly going to describe how this thing works. It's not important for you to understand or to know, but the way in which the outcome is important. So there is a person who's breathing in and out into this mouthpiece. The nose is blocked, And as they breathe into the mouthpiece, certain things happen in this drum. You don't have to know how, which result in this little pulley system being pulled up or being pushed down. Now, if you look carefully, you'll see that in this particular device, there is a little revolving drum going here. Okay, rotating, revolving. Does it make any difference? The Earth revolves on its axis. Okay, we'll call it a revolving. And what you can see is that there's a little pin here, and on the revolving drum, what if I decided I was going to call it? On the drum is a piece of paper. As the drum turns around, there we go. As the drum turns around, the pen records a little line on the paper on the drum. Obviously, as the pulley goes up, the pen will go up, and as the pulley comes down, the pen will go down. The extent to which it goes up or goes down depends on the volume of air that this individual is pushing into the whole device. So at the end, there will be a spirometer trace or a spirogram, and that simply says when this person breathed without force, this is how much air they breathed in and how much air they breathed out, etc., etc. So it can be read, and I'll explain that to you now. More modern ones record directly onto a computer. So there's a trace on the computer that can be read. Okay. And the trace would look something like this, but I'll talk about that just now. Okay. So the lungs can hold approximately 6 liters of air when fully inflated. A person breathing normally at rest takes in and expels or exhales between 500 and 600 milliliters. So that's about a half a liter if you consider a liter of milk in the fridge. And this is known as tidal volume. So what a person breathes in and breathes out under normal restful circumstances. So if you're just sitting at your computer, that would be tidal volume. It's, however, possible to force an inhalation. So if you breathe in as deeply as you possibly can, the volume over and above your normal tidal volume is called the inspiratory reserve volume. And on the following slide, it is referred to, it is shown as being forced inhalation volume. It means exactly the same thing. So that is normal breathing in volume minus tidal volume. At the end of normal restful breathing out, that's obviously tidal volume breathing out, it's possible to expel more air than would be breathed out during normal tidal breathing. And that is expiratory reserve volume. It's about a liter of air, and it's shown on the following slide as forced exhalation volume. Okay, so let me show you the next slide, and then I'll come back to this one. So tidal volume, normal restful breathing in, breathing out. And you can see here how much you can read off how much tidal volume is. So this is a spirometer trace or a spirogram. And what you can see is over time, this particular individual breathed differently. And so the lung volume is in milliliters, which obviously is USA spelling because it's ERS, and that's on the y-axis. So tidal volume is normal restful breathing in, breathing out, breathing in, breathing out, and it's not a great volume. It's about 500 mils. Okay. Then this individual forced in an inhalation. So this is that forced inhalation volume that occurred with forceful breathing and forced exhalation volume. Now, if I asked you to read that off, it would be the difference between normal tidal volume and the maximum volume inhaled. So it's only this figure here. You wouldn't include the figure of tidal volume. And exactly the same with the forced exhalation. It would be from there down to there. It wouldn't include the figure for normal tidal volume. So that would be the inspiratory reserve volume or inspiratory reserve volume and the expiratory reserve volume. Okay. Vital capacity is the total volume of air that can be breathed out or expired after a maximum inspiration. So vital capacity is if a person has taken the deepest possible inhaled breath and pushes out maximum volume of air that they can breathe out after that, then that total volume is referred to as vital capacity. Obviously then, total lung capacity would be how much a person can breathe in or out. Well, no, sorry, I shouldn't have said how much they can breathe in or out. It refers to how much air total can go into the lungs. But we've got this little bit of air here. It's just over a liter, and it's called residual volume. And so residual volume is the quantity of air that is left in the lungs after expiratory reserve volume is exhaled. In other words, no matter how deeply a person breathes out, there's always a small quantity of air left behind in the lungs. And for this person, it was just over 1,000 milliliters. In other words, just over a liter of air. So let's talk about residual volume. The lungs are never completely empty. There's always some air left in the lungs after even a maximal exhalation. This residual volume is important because if it didn't exist, and if the lungs emptied completely, the lung tissues would stick together, and the energy required to reinflate the lung would be too great to overcome. So in other words, the person wouldn't be able to recover from that. Therefore, there's always some air remaining in the lungs. So residual volume is also important for preventing large fluctuations in respiratory gases. That's carbon dioxide and oxygen. And it's the only lung volume that can't be measured directly because it's impossible to completely empty the lung of air. This volume can only be calculated, it can't actually be measured. Now, there's another terribly important reason to have respiratory volume, residual volume, and that is it's important for a person to be doing gaseous exchange all the time, or any organism to be doing gaseous exchange all the time. So you can't have a person breathes in and then breathes out, and then during the time from the beginning of breathing out to the next inhalation, you can't have no gaseous exchange occurring. You've always got to have gaseous exchange 24/7, 365 and a quarter. Gaseous exchange has to carry on happening. You can't have gaseous exchange, then a break, and then not, etc. And so it's the oxygen that is left in the air in the residual volume that is diffused into the capillaries passing the lungs between inhalations. Now, this air that is there in the residual volume is not static air. It doesn't stay there all the time. It's not you took your first breath when you inhaled when you were born, and those molecules of gas are still the exact same ones that are in your air in the residual volume in your lungs now today at age whatever, 16, 17. It changes all the time. So it's constantly replaced every time there's an inhalation. So it is air that does still contain oxygen, and gaseous exchange can occur as a result of that. Okay, let's talk about lung diseases. So the first one we're going to talk about is asthma. So asthma is a condition in which the bronchioles narrow. And the way in which they narrow, there are two reasons why. Firstly, an inflammation causes swelling, which if you look, this is a normal bronchiole, this is a bronchiole in the middle of an asthma attack. Okay, so what you can see is the lumen, in other words, the pathway down which the air rich in oxygen is able to travel. You can see that with inflammation, the lumen has become much smaller because the bronchial wall has swollen. That's the first reason. The second reason is that these circular muscles which occur around the walls of bronchioles, and it's not cartilage, there's no cartilage in bronchioles. This is a bit confusing on this diagram. Those circular muscles contract, and therefore they constrict the bronchioles. And that means an inadequate volume of air is able to enter the lungs and leave the lungs. So it causes breathing to become difficult, it triggers coughing, it triggers wheezing, and what is called shortness of breath, wherein a person can't breathe in adequately or breathe out adequately. Now, the degree of asthma in people and the frequency of asthma attacks varies considerably. So for some people, asthma is a minor nuisance, and for others, it can be a major problem that can interfere with daily activities and may lead to a life-threatening asthma attack. And in fact, my cousin died having an asthma attack. She was not taken to hospital quickly enough and actually died. So asthma can't be cured, but its symptoms can be controlled. And it's normally treated using medication that reduces the inflammation. In other words, the little bronchioles wouldn't be so narrow, and causes the airways to dilate, in other words, widen. So you know that people normally use an asthma pump to reduce the signs of an asthma attack, but apparently a lot of people use an asthma pump incorrectly. They think they use it correctly, and I don't know the correct ways of doing it, but when I was researching this PowerPoint, I could see a number of articles on the fact that most people use asthma pumps incorrectly and don't get maximum benefit from asthma pumps. Right, so what are the symptoms of asthma? They may vary from person to person. Some people have very infrequent asthma attacks, as I've said, with symptoms only occurring at certain times, such as when they exercise, or they may have those symptoms all the time. And the signs and symptoms include shortness of breath, tightness of the chest or pain, and that means inability to breathe, trouble sleeping caused by shortness of breath, coughing, or wheezing, and then a whistling or wheezing sound when exhaling. And this is a common sign of asthma in children. And then when a person who's prone to asthma gets a respiratory virus, in other words, a cold or the flu, which affects the breathing system, then asthma attacks tend to be worsened. So for some people, asthma signs and symptoms flare up in certain situations. For example, they may get asthma attacks when they exercise, and that's called exercise-induced asthma. And it may be worse when the air is cold and dry. Occupational asthma, triggered by workplace irritants such as chemical fumes, gases, or dust in the workplace. Or allergy-induced asthma, triggered by airborne substances such as pollen, mold spores. Remember, this is USA spelling, MOULD spores. Feces of cockroaches, or particles of skin and dry saliva shed by pets, which is known as pet dander. And this is what causes certain people to be allergic to certain animals. Like you may have a person who is allergic to certain cats, for example, not necessarily all of them, but certain cats, or even certain dogs. And if you remember the story of the Obamas in the White House, you will remember that one of the Obama family members, I can't remember who it was very allergic to dogs. And so when somebody gave them a dog, they had to give them a dog which did not cause allergies. So that is because of the pet dander, that particular subspecies of dog. I don't know, what would you call it? That particular kind of dog didn't have a high pet dander load. Okay. The second disease concerned with the breathing system that we're going to talk about is tuberculosis. And this is caused by a bacterium, Mycobacterium tuberculosis. Here is a falsely colored scan electron micrograph of that particular kind of bacterium. And while it can affect various parts in the body, it most often affects the lungs. So it's possible to get tuberculosis of the bones and other parts of the body. While we're here, let's talk about this as being a scientific name. And you know it's a scientific name because it is a two-word name and it is typed in italics. So remember the first name is the genus name, and the second one is the species name. Remember, the genus is always written with a capital letter and the species is always written with a lowercase letter. And remember that if we ask you something like this, about this in a test or exam or any assessment, you underline it when you write it. Now, I don't care about you picking up a ruler to underline it. I'm fine with you doing a freehand line, but you will lose marks if you don't underline it. You will also lose marks if you don't write the genus name with a capital letter or the species name with a lowercase letter. Remember, if I say to you something like, what is the genus name of the bacterium that causes tuberculosis? If you write the entire scientific name, you get naught. This is the genus name. Don't write the whole thing if you asked only for the genus name. And exactly the same applies to the species name. You only write the species name. And they often ask you this kind of thing in the matric exams. Okay. So common symptoms of active lung tuberculosis are a cough with sputum. That means one which actually coughs up mucus. And quite often there would be blood in that sputum. Then chest pains, weakness, weight loss, fever, and night sweats are all symptoms of tuberculosis. And tuberculosis is spread from person to person through the air. When a person with lung tuberculosis coughs, or sneezes, or spits, or talks, and has droplets of mucus going out or saliva going out together with the speaking, then they propel the tuberculosis bacterium into the air. And a person who's uninfected only needs to inhale a few of these bacterial droplets to become infected. All right. So tuberculosis is a treatable and curable disease. Active drug-susceptible tuberculosis is treated with a standard 6-month course of 4 antimicrobial drugs that are provided, together with information and support to the patient by a health worker or a trained volunteer. Without such support, treatment adherence is more difficult. So that means that it's very easy for a person to become disheartened or perhaps to start feeling better and stop taking the medication, etc. And it's terribly important that they are consistently monitored and consistently encouraged to remember to get new meds every month and to continue to take the medicine every single day, even although it is 4 drugs per day. It is believed that worldwide, between the year 2000 and 2018, an estimated 58 million lives were saved through the diagnosis of tuberculosis and the treatment of that. So doctors usually treat tuberculosis with a combination of 4 different drugs. And these are examples of the particular drugs, don't obsess. And this combination is referred to as first-line treatment. The therapy usually lasts 6 months or longer. It's very important that these medications are taken as prescribed to prevent the bacterium from becoming resistant to the drugs. It is also important that all of the patient's close contacts are screened for tuberculosis so that they can be treated if they are infected. Now, there are such things as tuberculosis strains that are resistant to certain of the drugs. And these are referred to as multidrug resistant tuberculosis bacteria. Now, if a person is infected with multidrug resistant tuberculosis and they infect another person, then the person who has just become infected has also got multidrug resistant tuberculosis. They haven't got the one that will respond to first-line treatment. So this is a problem. So tuberculosis strains that are resistant to the 2 most effective tuberculosis antibiotics are called multidrug resistant, or XDR-TB. To cure multidrug resistant TB, patients must take combinations of second-line tuberculosis medications, and there are some examples there. Now, these second-line ones are unpleasant. They're much more likely to cause side effects than the first-line drugs are, and they're not as effective, and therefore they've got to be taken for up to 2 years. So you can imagine that getting multi-drug resistant tuberculosis is much more problematic than getting tuberculosis that is responsive to the first-line drugs. And now, even worse than that, there is extensively drug-resistant XDR-TB. And these strains are resistant to most of the drugs that are available for treating tuberculosis. That makes it very difficult to treat somebody infected with one of these strains, and sometimes surgery is necessary to remove the diseased portion of the lungs. So in 1921, 2 scientists, I presume working in France, judging by their French names that I'm not prepared to pronounce, they were working on the prevention of tuberculosis. And they developed a vaccine called the BCG vaccine. And you will hear it talked about quite a lot at the moment. It is often given to infants and small children in countries where tuberculosis is common. So by law, babies in South Africa have to be given this kind of vaccination. Sadly, even though a person has been vaccinated in childhood, it doesn't appear that this particular vaccine is very good at protecting adults against tuberculosis. Historically, tuberculosis didn't used to be able to be treated. So if an individual was infected with tuberculosis, say pre-1940, and then tuberculosis was often referred to as consumption. So it referred to the fact that a person seemed to be eaten up from within. So a person who got consumption or tuberculosis pre the 1940-ish period of time, there was absolutely nothing that could be done to cure them. And so they used to be sent away to what was called a sanitarium. And there it would be a place where there would be lots of fresh air. They weren't living in a polluted environment, and they would have a lot of rest and a lot of healthy food, lots of vegetables, etc., etc. And sometimes people who were treated in this kind of way would actually eventually recuperate, but very often, unfortunately, they died. So let's talk about tuberculosis in South Africa. It's a serious public health issue, and about 450,000 people develop the disease in South Africa every year. And of those, about 270,000 are people living with HIV, with tuberculosis therefore being South Africa's leading cause of death. And about 89,000 people die from it every year in South Africa. In perspective, that's 10 people every hour. Now, there are effective treatments available, and the government has put a lot of money into fighting disease, but it needs a lot more. And one of the problems is that poverty contributes to the problem by making people less likely to seek care and to finish treatment. And poor nutrition can also reduce the chances of ever being cured. The average cost of a complete episode of tuberculosis under ideal circumstances can be almost 4,000 Rand. Then you've got to take into account the loss of earnings for a person, and that's a major burden in poor families. So it's often the person who's the income provider of a family who becomes infected with tuberculosis. Then they would have to take time off work to go and get medication every month. And you must remember that many people in South Africa live far away from hospitals, from doctors, from clinics, even from government clinics. And therefore, if they've got to go to the clinic every month to get their medication, as does happen, so a person doesn't get given 6 months worth of medication at once if they go to the clinic. They've got to return every single month and be checked up and then be given the next month worth of medication. So it's 1 day a month that they have to take off work. In addition, they've either got to walk a long distance to get to a clinic, or they've got to pay to catch a taxi, or even 2 taxis there and 2 taxis home again. So it costs people a lot of money to actually be infected with tuberculosis. And so it's a problematic diagnosis for a person to be diagnosed with tuberculosis. So currently it costs the government about 2,500 Rand to treat a straightforward case of tuberculosis. And this is scary, 115,000 Rand for multidrug resistant tuberculosis. Reaching the target of reducing deaths from tuberculosis by 90% would actually cost the South African government about 5 billion per year extra over and above what they're spending at the moment. But this would make the following plus factor in South Africa. So it has been calculated that by putting in this extra 5 billion into tuberculosis treatment per year, the South African government between 2016 and 2035 would give a total of 450,000 additional years of life to South Africans. And this is important because it's additional years of earning power, and that's important for the economy. So this graph is the incidence of tuberculosis per 100,000 people in South Africa over the years from 2008 to 2018. And it shows that the incidence of tuberculosis is actually decreasing. And I would imagine that this is linked very closely with the fact that people who are HIV positive are now able to access treatment. Now, before you were born, and this is quite scary because you're young, and for me it seems just like the other day, but in fact it was before you were born. Antiretroviral drugs for HIV were not available in South Africa. So if people wanted to get ARVs, they either had to travel to England or any place in Europe, or some of them were able to access ARVs in Swaziland. But it was hectic because people were dying. Lots of people were dying of HIV, and they were infecting other people more readily because they went on ARVs. But since ARVs became available, and when I say not so long ago, I'm talking about like 1998, which is not actually that long ago. That's 22 years ago, which for you seems like a long time ago, but in my mind, it's actually very recent. And so in the early 2000s, ARVs became available. And so people who were HIV positive who took antiretrovirals against HIV, their health became far, far better. And so they were less likely to get the opportunistic infections such as tuberculosis. And so you can see that the infection rate is much, much lower. Now remember, this is per 100,000 people in South Africa. Now, if you wanted to read off figures off this graph, it's not an easy one to read. Can you tell me why? And maybe this will inspire you to do beautiful graphs that I can read off values. Okay, so your homework today is to answer questions 1 and 2 of activity 5, pages 230 to 231. And that's enough for today.